here we go. It's always nice to come after Americans to speak as a Finn. So bear with me. And about Kai, they are from Vöyri, that small village in western Finland. I almost know them because I have flown over it several times. I'm cheering for them and you. Okay, I have a bit different approach, but I think you'll get the message. And we'll start with some high-tech Finnish graphics. Once upon a time, about 15 years ago, it was like this. A bit of Finnish, that's me, and of course that's the patient, and there is 3 colleagues. And it went like this, a bit. We met a patient in an ambulance on the road. Elderly lady, suddenly unconscious after a meal. IGL works good. Respiratory rate 8 per minute, blood pressure 50/80. Sinus, Glasgow 3, normoglycemic, no signs of trauma. Then I'll wait. And the first one, you can imagine who this is. Oh, passed out and no trauma. Well, intracranial bleeding causes that and this and that. Doesn't sound like my patient. And no fever, and no neurological focal findings, no seizures. Doesn't sound like my patient. Doesn't sound like my patient. A bit of a problem, if you know what I mean. And then, I should keep going, there's another mission for us. Oh, and now comes blueberry soup from her mouth. This is not my patient. But they make a decision, and you know what it is. Let's go to the head CT and then decide which of us will treat the patient. Okay, it's a bit over-exaggerated, but still you get the point. 1st of October 2012 in Hämeenlinna, Finland, we were the first clinic who got rights to do some emergency medicine big time. And the nurse said to us, "What are you guys doing here then?" And we said, "We treat every patient who comes through the door." And the nurse was surprised. "Can you do that? You take care of all of her or his things?" Yes, that's the point. And that was a bit hard them to recognize that we truly can do that. Of course, we were at the beginning of our path, so what's happened? This is the Kanta-Häme Central Hospital. You get the picture of what we did here there. 170,000 people, middle-sized secondary care center, 30,000 patients in EMS, and in our ED, 45,000 visits per year. So not much by Atlanta standards. So, but okay, it's there. Don't worry about it. In southern Finland. So the birth of emergency medicine, it was decided that it's 6 years specialist training from 2013. We got a little start before that. And the goal was clear. It was to educate hardcore professionals to central and university hospitals who really can master every acute patient which comes through the doors. That's what we do. But who will educate us? Another problem. There were 2 US educated EPs in Finland at that time. Will they train us? No. The grandparents of EM, who were responsible, they were given free but uniform rights to educate. The state was behind us. And of course, there was a need of experienced seniors who worked on the ERs or EDs, mainly in internal medicine, surgery, and anesthesiology. And they did a written exam test, and then they started to teach us. Then that went rather well, but there were quite a few number of those people. So what we did, we taught each other. I did the simulation instruction. My colleague did ultrasound, and we educated each other. And then, after the 2 or 3 or 4 years in a central hospital, we all went to the university hospital because, you know, the Empire Strikes Back. And it was like this. How can some emergency medicine doctor guide us through the trauma patient? How on earth will he or she know if the patient needs size 10 or 15 gamma nail? We tried to say that wasn't the point. And in our hospital, you can imagine who is eye doc. What? EPs? They will take all our patients. Like, that's a bad thing. And after they realized what we are doing, in 3 years, they were like, oh, thank God you are here. This patient is about to crash. Can you help me? Okay, the chief of our ED was one of the grandparents, and he became professor in EM, so we have a little advantage. And Tapio Innavo, one of the 2 US EPs, was the first drill instructor. And of course, we did shifts together with the junior docs as equal. And we did a lot of work at that time, and I still think there is still a lack of neurologists in Finland. But especially in Hämeenlinna, we take care of neurological patients, especially AIS patients. And there was, of course, some research, and we did quite well. DNT is still 20 or, I think, 19 minutes. And we take care of ENT, ophthalmology, and children. Of course, we have pediatrics in our hospital, but we also took care of them. And one big bonus for us, and in Finland, that Thursdays are a day of emergency medicine. We have all Finns lecture in the morning. All the clinics will come. And of course, in Thursdays, there were patient cases, theory in all fields of acute medicine, procedures, lectures, ultrasound, simulations, and because of our beloved staff, there was a great collaboration. And also, what's different back then, that we were there with the nurses and staff, not like before, that the surgeon or internist medicine, they came for 2 months and then they leave. We are about to stay. Okay, that was in Central Hospital, that basic training. Then the University Hospital, and that was quite something. I'm the small e-doc here. That's me. You can read. I've saved your ears. Read yourself. That was fun. How many complications? And then I said 2. That was my mistake, because I didn't realize that some other doctor was given one of them some diazepam. and I gave some propofol. Saturation was 17. Okay, but that went well. But he said, "Oh, really? A few hundred? Okay. I think you should first observe for elective cardioversion patients. Let's say 5 of them." I said, "Oh, okay. I have made them about 200 or 300, but okay. Then you should write some guidelines to the ER, and after that you can give some propofol. But when you are about to give, call a medium ADOC." Okay. Then I did that, and I called, and I knew the doctor who was answering, and she said, "Why are you calling me?" Okay. Big boats turn slowly. It's still that is a problem. We have infiltrated now in university hospitals. In my university hospital, which I'm part of in EMS, EP will take care every patient, but trauma, major trauma, they are surgery. There is also the orthopedic or surgery, and they will take care of it. But we will strike them. Sorry if there's those ducks. Okay, what do we do today? EDs are now led almost everywhere in Finland by EP specialists every time. He or she will serve as a consult, triage, and handles the EMS calls also. One of us we don't directly treat patients as a leader, but we do go in our hospital. We go to the trauma alerts as a trauma leader, and also to the critically ill patients with the residents. We try to educate all of them. And of course, we are taking care of the residents, nurses, and all the other stuff, and the patient's flow, and we make sure that the ED is working properly. But residents, I think you know this. Every clinic in Finland uses European curriculum, and it's like this in Finland. Nowadays we have an application and interview, and we have to do primary care for 9 months, and we have a trial period of 6 months. Then the practical training, at least 4 years and 3 months. Of course, adults, internal medicine 6 months, surgery and traumatology 6 months, pediatrics 3, anesthesiology, ICU 6 months, EMS 3, and of course supplementary or optional practical training to achieve the training objectives. And of course research, always research, like me. And we have some courses in leadership and management. Okay, what else is included? ALS, like these courses. We go to the SWESEM, usually with an abstract. And of course, we get some lifelong friendships with like-minded people. That's the most important thing. So that's about it. That was some great American EP said in my first SWESEM back in 2016. I think I have all of 3 in some way. And also the right one. You can still choose, but you are here now. There's no turning back. Okay, thank you.